OU. I've been training PAs in the emergency department for 27 years. So a lot of the PAs that you become colleagues with, I know a whole bunch of them, just because we all work together. Today we're going to talk about an approach to the altered mental status. I think Dan has already warned you, Dr. McNeil has already warned you about a lot of mnemonics and acronyms that I like to use. And I get off on a lot of tangents because I've been teaching so long. I said, oh, there's something else I can talk about. And we'll end up over there in Oz when we're supposed to be talking about the altered mental status. And I apologize for that, but here we go. Talking about the approach to the altered mental patient. Tons of mnemonics. We're not going to really use any of these, but I just wanted you to know that my whole practice was based on mnemonics. I was kind of stupid in medical school. I just couldn't remember crap. So I had to come up with mnemonics. So most of the mnemonics I wrote on my own, and I'll share as many with you as come to mind as we get off on a tangent. So as we talk about approaching the patient with altered mental status, you really need a good plan of approach. You need a good attack. And that's really what it is. Whether the patient's comatose and totally out, or just kind of goofy. It's just kind of a goofy patient, or just kind of a weirdo that you're just not quite sure, is this their baseline or is this not their baseline? That's the kind of thing we're going to see in the ER. Now back up and I'll tell you, I was an ER doc for 33 years at the OU Trauma Center. So I'm losing my voice here. I've talked to PA students in the past who said, I won't name the name, but they'll talk about a professor. And every time she gets up, she says, well, I was an ER PA. Or somebody else will come up and say, every time they lecture, I want to remind you that I'm a family practice PA. And they were kind of making fun of her, mocking her, but it's really important to know, those are the lenses that I'm wearing. I'm wearing the lenses of an ER doc. I don't approach patients the same way the family practice person would, or an internal medicine person would. So don't make fun of her. Don't make fun of him. So the approach is everything. You have to have a really good approach, and it's just like saying your ABCs. You know how to say your ABCs over and over and over. If you do the same thing with your patient with altered mental status, over and over and over, you'll get there. So the very first thing you want to do, you got somebody who's laying there in front of you, whether they came by ambulance or they came from the waiting room, you want to prove it. You want to prove to yourself that they are really out. Now I'm not talking about somebody who's in full arrest. You can see that they're breathing, you can see that they're not dead, they've got a pulse, they've got a blood pressure, but they're just laying there. And the most effective thing you can do, I do this all the time, I get right down in their ear and go, open your eyes! You will be amazed at how many times they'll open their eyes. And you pretty much done a whole bunch of clinical workup because they were just sleepy or they're intoxicated or whatever. So if you just say, open your eyes as loud as you can, you probably can't say it as loud as I can, but if you really get down and do it, you'll be amazed at how many people will open their eyes. And now you've got a new situation to deal with. If they don't open their eyes, now you need to just not just think. Most people prefer the sternal rub, and they'll grind on the chest. And that's what you're supposed to do. You're supposed to grind on your chest. Now, if you got a husband or a wife, or mom and dad, or family and relatives, they don't want to see you going like this. So you have to kind of disguise it. You kind of put it over and you kind of cover it up, or what you're doing is say, hey, wake up, all the time, grinding on your chest. But you're seeing what's their response when you grind on their chest. Are they reaching up and grabbing? Do they open their eyes when you grind on their chest? Do they decorticate? Do they do cerebral? Want to know all the things that they're going to do when you try to hurt them. If they don't do anything, then you start going. You start squeezing nail beds on the right, nail beds on the left, in the toes, nail beds on the right, nail beds on the left. Again, seeing what do they do. If you're squeezing, a good way to do is just take a ballpoint pen and just put it there. The family doesn't have to see you do that. It's pretty easy to do and hide it. You just mash on the nail beds. Do they pull away? Do they reach out with their other hand to get you? Do they posture? You need to know all that stuff for the Glasgow-Coma scale. We're trying to develop a Glasgow-Coma scale. This is from the University of Glasgow. It's in Scotland. And they came up with the Glasgow-Coma scale. Sometimes they call it a Glasgow level. At OU, I promise you this is true. I called and talked to a doc in Purcell. He was trying to send me a patient at OU. And he was trying to send me a patient who was head injured. And I said, well, what's the Glasgow level? And he said, that's a send-out. And we won't get that back until Tuesday. It's not a send-out. It's not a lab test. It's a clinical test. You guys know the Glasgow-Coma scale? Okay. Remember, this is from the University of Glasgow. They don't allow cows on their campus. It's not Glasgow, it's Glasgow. Okay? Glasgow Coma scale is anywhere from 3 to 15. Even a potato in the middle of the road has got 3. You can't have a score of 0, 1, or 2. Dead head in the middle of the road is going to have 3. The best you can get is 15. And this is based on 3 different things: eye-opening, verbal response, and motor response. Now, it wouldn't be easy if it was just 5, 5, and 5, but it's not. It's 4, 5, and 6. So for eye-opening, the best you can get is 4 points, just spontaneous eye-opening. And it goes down from there. Opens to verbal stimuli, opens to pain. Verbal responses are oriented. For 4 points, they're confused. For 3 points, inappropriate words, and all the way down. Motor response, 6 points if they obey commands, 5 points if they localize, and on the way down. So here's the way I remember it. Underneath there, I got eyes, talks, and motors. Eyes is 4 letters, E-Y-E-S. The best you can get for eyes is 4 points. Then you work your way down. For verbal, my mnemonic thing I remember is talks. That's 5 points, because there's 5 letters in talks. And for motor response, the thing I remember is motors, because there's 6 letters in motors, and you get 6 points. So it's eyes, talks, motors. This is kind of a goofy thing I found online. It kind of describes what is decervical posturing, what is decorticate posturing. If you don't know, decorticate is when your fist comes towards the core. That's decorticate. Decervical is even worse, going down like this. So after you've done that, this is in a patient that you know is alive. They got a pulse and a blood pressure. You're not really worried that they're dead or going to die. If you get somebody that is totally comatose and you don't know, maybe they're going to die, maybe they're already dead, maybe they need CPR, that's when the ABCs come in. So the airway, breathing, circulation, disability, and exposure, always with C-spine control. It doesn't do any good to save somebody's life and they end up with a broken neck because you were jacking around in their neck or somebody else was jacking around in their neck. So if you don't know what happened to them, if they were in any kind of a trauma, you need to put a C-collar on them until we can clear their spine. So for airway, if they're talking to you, their airway's okay. For breathing, we're just listening to breath sounds. Are they equal bilaterally? We're looking for things like that. Circulation, we're checking the pulse, we're checking the blood pressure. The D in the emergency department world is disability. What is their disability? What do they do when you do the Glasgow Coma test on them? What do they do? And E, exposure, this really means you should get the patient totally exposed. Take off all their clothes. Doesn't matter. I can't tell you how many times, only because I took off all their clothes, did I find that he had a dozen fentanyl patches on his back. And that's what was wrong when he was overdosed on fentanyl. Or look underneath the armpit and there's a gunshot wound right there where somebody came up and tried to execute him. And if you didn't take off his clothes and look, you wouldn't see it. So the E is for exposure. This is hyperthermia, but it's really expose the patient. Don't let a patient lay there and not be buck naked, at least for a little bit. You got to find out what's going on there. Specifically for the trauma patient, and you've got to get them buck naked. You've got to get them buck naked. You're still doing the ABCs. If you don't know what happened to them, you've got to put a C-collar on them. Almost always they're going to arrive with a C-collar. The ambulance is going to bring them with a C-collar. But if they don't, you be the one to do it. You know how to clear a C-spine? This is the tangent again. This is the tangent. If somebody is awake and alert, this patient that we're dealing with finally wakes up, and you ask them, does your neck hurt? And they say, no, my neck doesn't hurt. So you can take their collar off and go up and down their spine, poking on the spinous process. Does that hurt? Does that hurt? Does that hurt? No, it doesn't hurt. Then you say, okay, can you pick up your head and put your chin on your chest? But stop if it hurts. That doesn't hurt. They're pretty much cleared, except if they're drunk or on drugs or otherwise incapacitated. Got back off my tangent. Vital signs. I got a mnemonic specifically for trauma, and I didn't make this one up, but they taught it to us in residency. It's, oh my, I've lost the vital signs. Oh my, I've lost the vital signs. Where O stands for oxygen, M stands for monitor, the other M stands for masked pants. You guys know what masked pants are? Masked trousers. It's like a great big balloon pants that you put up and they pump up, and they basically shunt all the blood from the lower all the way up. So if you've got somebody with a pelvic fracture or a femur fracture or something like that, you can put on mask pants and you can really get their blood pressure up. They still need to take care of what's wrong, but it's a temporizing thing. IV is IVs. Lost is labs. The, T for tubes, now we're talking about NG tubes, Foley's, chest tubes, and V is vital signs. So if you just remember that, imagine you're a PA and you're moonlighting in one of the ERs in Broken Toe, Oklahoma, where the last person that moonlighted was an ophthalmology resident who came in who really, ophthalmologists, they're great docs, but I'm not sure how they're doing the trauma. But you've got this mnemonic in hand. So here comes a trauma patient from a car wreck. You just remember the mnemonic. You tell the head nurse, everybody's gathered around. Remember, this is a small hospital. You say, hey, we're going to put this guy on oxygen right now. You put him on the monitor. If he's got a pelvic fracture or something like that, think about getting out the mask pants. Say, hey, I want to get an IV of normal saline and 18 gauge, at least 2 of those right now with normal saline. It's got to be normal saline. You can't be giving D5W or something like that. So 1 IV, 18 gauge, normal saline, 2 liters. Let's give that right away. Give me a CPC, a BMP, a UA, a pregnancy test, whatever you need. Let's get an NG tube ready to put down, but just to make sure that he hasn't got any kind of gastric obstruction. Maybe he needs it, maybe he doesn't. Let's get a Foley ready. Maybe he needs a Foley. We can monitor his urine output, but not before we do a rectal exam. If it's a man, you got to do a rectal exam to make sure his prostate is okay. If his prostate is high riding, then you have to do a retrograde urethrogram. So after you've done all, and give me a set of vital signs. So you wait about 5 minutes to come back and say, got the oxygen yet? Oh, I see the monitor's got a normal sinus rhythm. Got 2 IVs of normal saline. Okay, we got the CBC and the BMP cooking. Does he need a chest tube? Is the breath sounds equal bilaterally? Let's listen real quick and make sure they need a chest tube. Is that Foley in yet? What are his vital signs again? And the nurses will look around and say, man, that PA is way better than an ophthalmologist that came here. And it's just because you went through the mnemonic twice. And if you're ever stuck, just say, give me another set of vitals. That always works really good. It buys you time too. Just give me another set of vitals. So, if it's not trauma and it's drama, if it's a medical case, you still have to do your physical exam. Don't forget to do a physical exam. But this is a critical mnemonic. This is don't forget. And you may not be able to see it. The D stands for dextrose. And let's just go through it really quick. If your patient is hypoglycemic, just give them an amp of D50. As soon as you give an amp of D50, they're hypoglycemic, they're going to wake up. If they're hyperglycemic, if they're in a diabetic coma because they're hyperglycemic, an amp of D50 isn't going to hurt them at all. It's not going to hurt them at all, but you could certainly save their life and save a hospital and yourself a whole bunch of time and money if you give them D50 and they wake up, man, you're pretty much done. Or you can just get a blood sugar. Just say, I need a finger stick blood sugar. But don't forget the blood sugar. If you don't do a blood sugar and you don't give them D50, and your labs come back an hour later, blood sugar was 6, you're going to feel like an idiot. And the patient's going to be learn that about that as well. O stands for oxygen. Just give oxygen to everybody. If they're hypoxic, it's going to help them. You may see that they turn around right away. If it's a bad COPD, you're not going to hurt them by putting them on oxygen for a little while, just as a trial to see what's going on. You can also put a pulse ox on them and see what's their pulse ox. Do they need oxygen? The N is Narcan, in case they've overdosed on opiates. You're not going to hurt anybody by giving 2 milligrams of Narcan. If you don't have a line, you can put it down your ET tube. You can also put it sublingual, just pick a needle and stick it underneath their tongue and inject it that way. The T is thiamine. If they have altered mental status because of Wernicke-Korsakoff syndrome, you can fix that right away with thiamine. And the F is flumazenil. You guys know what that is? That's the antagonist to benzodiazepines. There's a little bit of a problem with that. All these others I've said, you can give that with no problem. But this, you can give this and may have a problem. If they're addicted to benzos and you reverse it, then they go into withdrawal. Now you're chasing your tail. Now you have to give them more benzos. Remember that people love to overdose on combined drugs. They love to overdose on Valium and heroin, or Valium and Percocets. So think about it. If they have a possible overdose of benzos and they possibly have an addiction to that, that can be a problem. This is a typical coma cocktail: thiamine, dextrose, Narcan, flumazenil. The other mnemonic users don't remember where the R stands for romazicon as opposed to flumazenil. And this is something that I haven't done this lecture in a long time. It'll come back to me. Dan, you know what it is? I see you looking quizzical back there.
What letter are we at?
Flumazenil.
What's the question, I'm sorry?
I don't know.
Oh, you mean for benzos over there?
Yeah, for benzos.
You're looking for the dose?
No.
I'm writing test questions, sorry.
All right, so we got this patient, we've done the don't forget, or the don't remember, if you prefer to use the trade name, Flumazenil. You still gotta do a physical exam, don't forget that. I've seen so many students, medical students, PA students, nurse practitioner students, I've seen so many of them forget to do their physical exam. You still have to do a physical. Now, this is not the physical that you guys have been practicing where you test every single reflex and every single muscle and every single group. This is just a really quick HEMT, heart, lungs, abdomen, quick neuro exam. And I think on Thursday or Friday, I'm scheduled to go through a quick neuro exam with you. It's just a quick exam to see if you can figure out what the heck's going on. So now you still got a patient that's altered mental status and you don't know what's going on. You've already done your physical, you've done the coma cocktail. Now it's time for labs. This is a mnemonic that will really help you. It's A, B, C, D, E, F, P. A, B, C, D, E, F, P. So here we go. A, it stands for, now let me tell you what these are. These are labs that you need to have in your mind right now as you're looking at a disoriented patient or a comatose patient. These are labs that you want to think about maybe ordering. You're not going to order every single lab on every patient. You're going to customize the lab you order to the situation, okay? The A stands for ABG. You might want to get an ABG on some of these people. Not only will it tell you what their oxygen status is, but you can also look at their pH status, their acid-base status. Also, ammonia. This one little letter, A for ammonia, has saved my butt so many times. There's so many people that come to the ER with hepatic encephalopathy. Their liver's dying, their ammonia is high, and it makes them act drunk or stuporous. And if you don't remember in your mnemonic that you got to get an ammonia level on those people, you're going to be chasing your tail forever and ever and ever. Get an ammonia level if there's a chance that they're an alcoholic or they've got hepatic or any kind of liver disease. The B is blood alcohol. You know, if you have a drunk in front of you, most people can tell. But if they're drinking vodka, it doesn't smell like booze. They don't have that smell like whiskey and all the other hard spirits. So if they're drinking vodka, you may not know it. So you might want to get a blood alcohol. C stands for a whole bunch of things. CBC. You get a CBC, see if they're anemic. Maybe they're bleeding out somewhere, and that's why they're acting goofy. You can get their chemistries and check their electrolytes. Any kind of electrolyte abnormality, hyponatremia, hypernatremia. Dan, my daughter Emily was admitted this summer with hyponatremia, sodium of 114. At 115, you start to have seizures. And my daughter got to 114 from drinking too much water. But if you don't remember to order chemistries, you're never going to know that. The CO is carbon monoxide. If it's somebody who's coming from a home that maybe has a fireplace or they're living in their car and got the motor running, anything that might make you think maybe this is a carbon monoxide exposure, you get carbon monoxide level. It's called carboxyhemoglobin. Chest x-ray, maybe they got a bad pneumonia. Maybe that's why they're acting goofy. Maybe they got ARDS. Chest x-ray, you can almost never go wrong ordering a chest x-ray. Unless they're pregnant, and then you want to use a pelvic shield to make sure you don't x-ray the baby. Blood cultures. It's not going to help you now. Cultures take at least 24 hours to come back. But if you get blood cultures on this patient today in the ER, tomorrow, if they're admitted, it's really going to help somebody. Someone's going to really be thankful that you thought to get blood cultures. CAT scan of the head. Maybe they got a big bleed. Maybe they got a pontine bleed. Maybe they have a huge stroke. CAT scan of the head is really, really expensive. And there's so many other things that could be causing this patient to be like this. Almost always the answer to, do you want to get a CAT scan of the head is, maybe, let's see what everything else shows. What if you say, yeah, I need a CAT scan of the head? So they load them up on the gurney, and they take them to x-ray, and they do a $2,000 CAT scan. And while they're over there, their lab work comes back and their sodium is 114. You just wasted a bunch of money. Wait and see if their sodium is 114. Wait and see what all their stuff comes back to tell you. If it comes back that there's nothing else in our labs, now we can go ahead and do a CAT scan. D stands for drug screen and drug levels. Drug screen means we're going to just routinely look for things like cocaine, marijuana, opiates, benzos, amphetamines, all, and we're just going to do a drug screen and see what we can find. As opposed to drug levels. If your patient is on Dilantin, you want to get a Dilantin level. If they're on phenobarb, you want a phenobarb level. If you've got their drug list, you should go through it and see what needs to have levels. Lithium is another big one. If you've got their med list. If you don't have their med list, I wouldn't just start ordering up Dilantin levels and things like that. But if you've got their med list, it really pays to start looking for things like that. EKG. Maybe they're having a heart attack. That can certainly make somebody act really, really weird. EKG can also show you dysrhythmias. If you have somebody with sinus tachycardia and widened QRS, you know what that would be? Say it again?
Is it Torsades?
It could be, but what's that from? Sinus tachycardia with widened QRS is typically a tricyclic overdose. So just looking at the EKG, if you see widened QRS, sinus tachycardia, you guess maybe this patient's got a tricyclic overdose. What if, what's better, weight? P, QRS, T. What's that? You see that on the EKG? I'll be surprised if you know. Nobody ever knows this one for sure. This is called a bat wing Q wave. This right here looks like a bat flying at you. It's subarachnoid bleed. Nobody knows why. But if you have somebody with a subarachnoid bleed, and usually in the precordial leads, but you can see in the inferior leads too, the T's are huge like this, sometimes going off the paper. So what kind of a star will you be when you get an EKG and say, got a subarachnoid bleed, let's go ahead and get that PET scan. The F stands for female. If it's a female patient, you're going to get a pregnancy test if she looks like she's childbearing age. Now, if it's an 80-year-old lady, you probably not going to do a pregnancy test on her. But if she's in the range and she's not able to tell you, then you need to get a pregnancy test. And even if she does tell you and you don't believe her, you better get a pregnancy test. The P stands for P. You want to get a urinalysis. And this is one you almost want to get on everybody. It may just be a bad UTI, and they're going into urosepsis. You can look at their specific gravity of the urinalysis to figure out if they're overhydrated or underhydrated. And PB is lead level. If it's a kid who's been eating the paint off the walls in an older home, maybe he's got plomism, maybe he's got lead poisoning. Right, so that's the end of the mnemonic. That's a lot of things to think of, but I think this is one you don't want to put in your iPhone or your BlackBerry. This is one you just kind of want to remember, because people will present to you and it just doesn't look good when you pull out your phone and you start looking. This is one you want to memorize. So our first patient is Martha. Martha, here's what happened to Martha. She's 85 years old, and she lives in the nursing home. A little bit demented anyway. But the nurse who takes care of her every single day in the nursing home says, there's something wrong about Martha. Martha is just not right today. There's something different. So she sends her by ambulance to you. What do you want to get? We'll go through it. You want to get an ABG on her? And I'll tell you right now, there's no wrong answers. This is the art of medicine. Anybody want to get an ABG on her? Nobody. How about an ammonia level? Nobody. Blood alcohol? Nobody. CBC?
Yeah.
Only 3 people want a CBC?
Yeah.
4 people, okay. Chemistries?
Yes.
Okay. Carbon monoxide? Probably not much fruit in carbon monoxide. So far I agree with you. I get a CBC in chemistry. I wouldn't get the ABG or the ammonia. Now what if she came in and I told you on physical exam she's got caput medusa, signs of hepatic failure, then you go ahead and get an ammonia. But, or if the nurse says, man, she's an alcoholic, she's been an alcoholic her whole life, then you want to think about that, but not Martha. Not Martha. Chest x-ray? Who would get one? Blood cultures. Who would get it? You would? Yeah, a smattering of people. It's kind of 50-50. I might, if I'd look and see, does she have a fever? Is she tachycardic? Is she hypotensive? All the things that might indicate that she's septic. Certainly can't hurt to get blood cultures. What about a CAT scan of her head?
No.
Wait, right? Wait! I'm going to do a drug screen, which is get urine and look for marijuana and cocaine. Anybody want to do that? All right, drug levels. We're going to look at her med list, right? We're going to get anything that needs to have a level drug. Want to get an EKG on her? You should say yes on this one, but if you don't, I'm not going to hold it against you. Pregnancy test? You should say no. If you don't, I'm not gonna hold it against you. Your analysis,
Yes.
how about a lead load? That would really be stretching, I think, but it's okay if you wanna do it, I don't think I've ever ordered a lead load. All right, switch patients. Now you got a 19-year-old girl, she's a drug addict. She's found outside of her apartment, on the front doorstep. Right, 19-year-old female, altered mental status found outside of her apartment, known to be a drug addict. On an ABG,
Yes.
ammonia,
Yes.
Yes.
blood alcohol,
Yes.
CBC, chemistries, carbon monoxide. I hear everybody say yes. She's found outside. And you would want to know about her apartment. Does she have a fireplace? Does she have a gas stove? Is she running some machinery inside of her house? But ordinarily, I'd probably say no to that. How about a chest x-ray? How about blood cultures? Anybody want to get blood cultures? Raise your hand if you want blood cultures. Couple. CAT scan? Wait and see. Go back to cultures. She's an IV drug abuser. You know, they can get endocarditis and sepsis pretty easy. You might want to rethink that. I think blood cultures might be handy. You could always wait and see if the CBC comes back with a white count of 30,000, and then go back and say, oh crap, maybe I better get some blood cultures. But remember, IV drug abusers can get septic and get endocarditis, and cultures will help you with that. Drug screen, who's going to routinely look for everything in the world under her? Yeah, I would. How about drug levels? You don't know anything about it. You just want to start ordering Dilantin and no, I wouldn't. EKG?
Yes.
Yeah, you may find this. You see people that are using methamphetamine suddenly get a subarachnoid bleed. Pregnancy test? And you want to get your analysis?
Yes.
And who wants to get a lead load? Somebody. Okay. Are you familiar with this way of drawing things out for labs? Everybody seen this? Okay, so here's our labs. Sodium is 148, potassium is 4.2, chloride's 105, CO2 is 6, BUN is 22, creatinine is 0.2, glucose 135, white count is 12.2, hemoglobin is 13.3, hematocrit is 34.4, platelets 156,000. Can you see all that? You see it? And there's her ABG. You guys asked for an ABG. Those are your analysis. Notice at the bottom there she has positive HCG. So what's wrong with it? Want to see the labs again? Okay. Here's the labs again. There's the ABG. There's the UA. Anybody know?
Her blood's very acidic.
What's that?
Her blood is very acidic.
Yes, exactly. She's very acidic. She got an acidosis. She definitely got an acidosis. You see that? That's here, 7.12. Is it metabolic acidosis or respiratory acidosis? It's metabolic acidosis. So the labs I just gave you, the answer is there. The answer is there is what's wrong with her, but let's talk about it. First thing to talk about is the gap. You guys familiar with the anion gap? Yes? No? Anion gap, you have the sodium minus the chloride and the bicarb together. So here the sodium is 148. Bicarb and chloride together is 105 plus 6, 111. So was it 37, something like that? Right, the normal gap is 12. And her gap is 37. This is not her numbers, this is just an example of how to do the anion gap. So she got an increased anion gap metabolic acidosis, right? You guys, she pointed out that this is a metabolic acidosis. That's right, this is a metabolic acidosis. So as soon as you identify metabolic acidosis, the first thing you want to do is decide, is it anion gap elevated or normal anion gap? If it's anion gap elevated, which is anion gap sodium minus chloride and the bicarb together, if it's anion gap elevated, then there's a long list of things that it's going to be. It's going to be in this next mnemonic I'm going to give you. And I got this picture up here. I don't know why that happened. I got this picture here of of pimps. You guys, when you go out on your rotations, when somebody starts asking you question after question after question, it's called pimping you. They're gonna pimp you. And this is the #1 pimp topic in the hospitals today. What's the cause, what are the causes of increased metabolic acidosis, all right? In med school, they teach a mnemonic. In nurse practitioner school, they teach a mnemonic. And where I went to residency, they taught us a more expanded mnemonic, and over the years, I've expanded the mnemonic even more. So my mnemonic, I think, is the best around, but you decide. The differential, so what we're talking about, these are all the things that cause increased anion gap metabolic acidosis. It's got to be one of these things. That's pretty cool, really. It's got to be one of these things. Inferior mnemonic is Elm Park. A lot of people use Elm Park. Nice little picture of Elm Park, but not a good mnemonic. Some people use Mud Pile Cat. I got some good pictures of Mud Pile Cats. And even Katniss from the Hunger Games, Mud Pile Cat. This is the one I use, Mud Pile Cats. So, this is absolutely critical. If you're going to get pimped on this, please don't be that student that pulls out your iPhone or pulls out your BlackBerry. Commit this one to memory. You've got to know this, okay? Mud Pile Cats. So we're going to go through Mud Pile Cats. The M is methanol. Somebody who's drinking methanol, trying to get drunk, is going to have an anion gap acidosis, and you're really, really sick. I'll talk to you in just a minute about how we actually diagnose that. Metformin is a diabetes drug. It tends to have as a side effect lactic acidosis, and lactic acidosis can cause an increased anion gap acidosis. Uremia. How are we going to test for uremia? Well, look at the BU and creatinine. If the BU and creatinine are elevated, they got uremia. If their BU and creatinine are normal, they don't got it. That's pretty easy. D. It's DKA. How are we going to test for that?
ABG.
Just looking at their labs, the chemistries, right? They've got high blood sugars, they're going to have high ketones, they're going to have an anion gap that's elevated, they're going to have, so a lot of times serum ketones are going to be very, very acidic. That should be very easy to diagnose. P. Formaldehyde and fenformin. Formaldehyde is a drug they used to use in surgery a long time ago. Fenformin is an older form of metformin. It's an old diabetes drug. I'll tell you, nobody uses formaldehyde and nobody uses fenformin anymore ever. I don't even know if it's even on the market, but it lives on in the mnemonic. And your preceptors are still going to ask you and expect you to remember the P and the mnemonic. So just remember formaldehyde and fenformin, even though you'll never ever miss it. That's why it's such a great pen question. I stands for INH. It's the drug they use for tuberculosis, isoniazid. How are we going to diagnose that? That's really hard. That's a hard one to diagnose. This is the one where you hope that you get a chest X-ray and you see little goobers up at the apices that says, maybe this guy's got tuberculosis. Iron, how are we going to diagnose an iron overdose? You can get an iron level and a TIBC. If the iron level is greater than the TIBC, then they've got an iron overdose. When I was an intern years and years ago, our only option was to give them deferoxamine. It's a chelating agent. So we got this kid comes in and mom says, you took an overdose of his Flintstones vitamins with iron, which they happen a lot. We just give them a dose of Desferol, a deferoxamine chelating agent, and watch and see if their urine turned out red. It's called Vinrose. If their urine comes out red, then they're an iron overdose. And you know what you do? You just keep giving them shots until the urine clears up. It's kind of a nasty thing to have to do to the kid. But that's the way it works. Nowadays, we don't do that. We just get an iron and a TIBC. Look and see if the iron is greater than the TIBC. L. That's the lactic acidosis. Now, this is the fly in the ointment. This is bad because a whole bunch of things cause lactic acidosis. Sepsis, bowel ischemia, bowel infarct, a whole bunch of things that cause lactic acidosis. So when I said it's got to be one of these things, well, it's true. It's got to be one of these things, and one of these things is lactic acidosis. But there's still more limbs we got to follow to figure out what's causing the lactic acidosis. So this is really the fly in the ointment. And the lactic acidosis may just be from metformin. E, ethylene glycol. I'll talk about that when I go with methanol in just a second. C, cyanide. How are we gonna diagnose that? And you just almost can't. You just almost can't unless you're in a special population of people, about 1/3 of the people who smell their breath. It smells like bitter almonds. Only about 1/3 of the people can smell the bitter almonds. So if they get a cyanide overdose, they're gonna die. Unless they get to you and you're one of those people that can smell the bitter almonds and you know how to treat it. Cocaine, we're gonna find that on our drug screen. Alcoholic ketoacidosis. Now this is really important for you to hear. Make sure you hear me say this. Alcohol does not cause an anion gap acidosis. Alcohol does not do it. But alcohol can make you do nothing but drink and not eat like you're supposed to, and you can get ketoacidosis as a result of malnutrition. So it lives on in the mnemonic like that. Alcoholic ketoacidosis, just because they're not supporting themselves with nutrition like they're supposed to. Alcohol itself does not cause a anion gap acidosis. Aspirin, that's the other A in the mnemonic. How are we going to test for that? You get an aspirin, yeah. You get a salicylate level. How do you die from that? My first death ever was a 16-year-old girl overdosed on aspirin. And I thought I was this great doc out of residency, and nobody's ever going to die. And my first shift, this girl died. They get pulmonary edema, and it gets to the point where, man, you just can't save it. You just can't save it at all. Go off on a tangent here. A lot of people overdose on Tylenol, and Tylenol is in everything. I mean, you just look around. Tylenol's in almost every product at 7-Eleven, it seems like. And Tylenol is one of those silent killers that doesn't cause a toxidrome. You know, if you take aspirin, I can see you clinically and see that you've got a respiratory alkalosis and a metabolic acidosis, and you've got tachypnea, you're breathing too fast, you're starting to get pulmonary edema. Wow, that must be an aspirin overdose. You can overdose on cocaine, and say, wow, he's tachycardic, his pupils are dilated, he's sweaty, he must have died. But Tylenol doesn't do anything like that. You can't look at somebody and say, he's overdosed on Tylenol, until 3 days later when they start to die. They start to turn jaundiced and they start to die. So that's why Tylenol is really, really important to think about it, especially if you're looking at a psych patient. I think that's on another day, sorry. T, it's toluene. That's the active ingredient in paint. So you see it with paint sniffers and paint puffers. It's also in whiteout. People are sniffing glue and whiteout and things like that. So how are we going to diagnose that? Almost always they're going to have paint around their nose and around their mouth. The way they do it is they put it in a brown paper bag and they hold the bag, they spray the paint into the bag, and then they hold the bag up to their face and they just huff it. So their mouth and nose will kind of turn the color of the paint. You know which paint is preferred? Gold. Why? It's got more toluene. It's got more toluene. And second best is silver. S, starvation ketosis. If somebody just goes on a drastic diet and just stops eating, they can get an anion gap acidosis just from that. Just like the alcoholic who caused alcoholic ketoacidosis. It's along the same lines as the alcohol, starvation ketosis. All right, let's talk. We didn't talk about methanol or ethylene glycol. I want to talk about that real quick. How are we going to diagnose methanol? Anybody know? I'm going to draw that. Can you guys see this when I write up here? So you have to order, you can order a methanol level. That's what usually people yell out, methanol level. And I always say, okay, but that'll be back on Thursday. That's not going to help you. Methanol level, it doesn't really come back on Thursday. But it's important for you to remember this. You order the osmolality. You just write down I need a serum osmolality. Here's how they do a serum osmolality. It's 2 times the sodium plus the glucose over 18 plus the UN over 2.8 plus ETOH over 4.6. So that's the formula that they use. So you call the lab and say, I need an osmolality. And they write back. All they do is they just plug in sodium, glucose, VUN, ETOH into this formula, and they write back, here's your osmolality, Dr. Lovelace, is 300. that good, is that bad? You know, that's normal, 300 is normal. What you gotta tell the lab is, how'd you do that? And they said, well, we calculated it uses 2 times the sodium plus glucose, blah, blah. Well, that's a calculated one. I need a measured one. Ah, man, how do you? Because they don't like to have to do that. It's a really hard test, the measured osmolality. Calculated is so easy, I mean, you can do that right here in your head with the calculator. They want you to measure, you gotta get them measured. And oh, by the way, there's 2 ways to measure it. Freezing point depression, boiling point depression. Can we do boiling point? Nope, it's gotta be freezing point depression. That's the only way you can do it. If you do boiling point, you're gonna boil off the methanol. Now they're really hacked off at you. You gotta do a freezing point depression. But they do it and they write back and say, oh, it came back 450. What? Calculated is 300, measured is 450. Calculated versus measured. That's the osmolar gap. It's a gap of 150, right? They measured it at 450 and they calculated 300. It's a gap of 150. That's methanol. That's what methanol is doing to you. Okay? Exact same thing for ethylene glycol. Exact same thing for ethylene glycol. So, how does methanol kill you? Anybody know? Put it up here real quick. Methanol does not kill you. Its byproduct does. Methanol is broken down into formic acid. And that's what kills you. So how do we treat it? We treat them, anybody know? With alcohol. To get from methanol to formic acid, you need alcohol dehydrogenase. Alcohol dehydrogenase is what's required to go from methanol to formic acid. So what we do is we give the patient alcohol. And what does it do? It comes in here and it ties up all the alcohol dehydrogenase. So, your patient's drunk now, but their methanol is not being converted to formic acid because the alcohol dehydrogenase is being used up by the ethanol. And the same is true, I'll just skip forward, ethylene glycol does not kill you. It's metabolized to hippuric acid, which is what kills you, and it also causes calcium oxalate crystals in the urine. How can we diagnose that? We can look for calcium oxalate crystals in the urine. Ethylene glycol is also something that is frequently seen in antifreeze. What they do is they'll put fluorescein dye in antifreeze. You know the fluorescein that you put in the eye to see for corneal abrasion? They'll put that in the antifreeze. So if you drink antifreeze thinking you're going to get drunk, your urine's going to glow in the dark. So that's something else you can do in the ER. You just shine a black light on the urine and see if it glows in the dark. But ethylene glycol is metabolized to hippuric acid, and ETOH does the same thing. It ties up the alcohol dehydrogenase. So how much alcohol you want to get? Good question. You want their level to be about 150. You know, drunk is 0.08 or 100 or 0.1, depending on which standardization you're using. You want them to be 1.5 times drunk, 150. And if you're working in Broken Toe, Oklahoma, they're not going to have IV alcohol. You have to go to the liquor store and buy some whiskey or something and keep them drunk. Now remember, all we're doing is tying up the alcohol dehydrogenase. That's all we're doing. We still got to get rid of this methanol. You know how to do that? Dialysis. We still got to go to dialysis and get rid of this methanol or ethylene glycol. Here's where people make a huge mistake. You go to diet, you get the patient on ETOH, their level's 150, and okay, let's take them to dialysis. And as they're dialyzing off methanol, but they're also dialyzing alcohol also. And all of a sudden, alcohol dehydrogenase starts working on what's left, and you got formic acid. So you got to turn the drip up. You need your drip to be higher when you start going to dialysis. Does that make sense? Seems confused to me. All right. So this is the osmolar gap. Remember, it's calculated versus measured. I'm amazed that even ER docs that I train still don't know this. We're talking about the difference in the calculated and the measured, with the gap that goes along with that. Skip all that. All right, so we talked about the treatment for methanol and ethylene glycol, since it's the exact same thing. What about uremia? If your patient turns out to have high BUN and high creatinine, how are you going to treat them? That's pretty easy, just admit them to somebody who knows. Put them in under medicine, and they'll put them on IV fluids and do whatever it is they do. It's not a whole lot to do in the emergency department. What about DKA? I'm going to treat DKA, diabetic ketoacidosis. If you have a test question and they say, what's the #1 treatment for DKA, and they're going to list potassium, fluids, insulin, bicarb. There's only one right answer, it's IV fluids. Obviously, you need all those things. You need IV saline, you need potassium. Should I go into that, Dr. Neal? wasn't part of the lecture, but it looks like I'm ahead of time. So the guys are stretching my brain because we haven't talked about this stuff in so long. So you got the cells here. Potassium lives inside the cell, right? And in the bloodstream, hydrogen ions, and as you get more acidotic, your hydrogen ions go up. More and more hydrogen ions. And what happens, this is especially true for diabetic ketoacidosis, the hydrogen ion goes into the cell and kicks out the potassium. Potassium comes out the cell. So now they flip-flop. And now you're peeing out potassium. You're peeing out potassium. But when you do your blood draw, when you draw your labs, potassium looks normal because it keeps getting kicked out of the cell. The hydrogen keeps going in, potassium keeps coming out. So when you draw your labs, potassium looks fine. We're not worried about that. But they're peeing out potassium as fast as it's coming out of the cell. Now you come along and you treat them. You treat them with bicarb and insulin and IV fluids, and suddenly those hydrogen ions come back out, potassium ions go back in, and guess what? You plummet. Potassium goes way, way low. People understand you're losing potassium the whole time. And I bet I haven't done that little talk in 10 years. Sorry about that. Where are we? Formaldehyde fenformin. That just lives on for the pimps. INH. How are we going to treat INH? Somebody's overdosing now. I wouldn't expect you to know this. There's a mnemonic that I've created. Oh, I didn't mention this. In the big cities, instead of alcohol for methanol and ethylene glycol, they have fomepizole. It does the same thing that alcohol does. It ties up the alcohol dehydrogenase, but it's very, very expensive. So just know that it's one of your choices: fomepizole or alcohol. I'm way behind the slides. Here's your IV drips of alcohol. Right, INH. So I have a mnemonic that involves INH. It's not for INH. But it's called split C. This is the mnemonic. Let's put it up there. Split C. These are all the things that you might want to use bicarb for. Somebody's overdosed on salicylates. Somebody's overdosed on phenobarbs. Somebody's overdosed on lithium. Somebody's overdosed on INH. Somebody overdosed on tricyclics and cocaine. There's a couple caveats here and things you need to know. Go back up to INH. You start them on an alkaline drip, bicarb, on a bicarb drip. But they start seizing. There's only one drug that's going to fix them if they start to seize. Anybody know that? You can throw Valium at them, you can throw Dilantin. It's pyridoxine, vitamin B6. And it's just something you need to tuck away in the back of your mind. If I've got somebody who's overdosed on INH, B6 is the only thing that can stop them from seizing. And when they start pimping you, they're going to be really impressed with you later.
Are you saying B or V? B as in boy?
B as in boy.
Okay.
Yeah, pyridoxine, vitamin B6, thanks. So, I've been talking for an hour and 10 minutes, or almost an hour. What I'm going to tell you now is the most important thing that I'm going to say today. Tricyclics and bicarb. If somebody's overdosed on tricyclics, and there's a whole bunch of them every day in the ER, people overdosing on tricyclics, Elavil, and amitriptyline, all the tricyclic antidepressants, they need bicarb. Bicarb is a panacea. If they come in V-fib, you can shock, epi shock. Not gonna help until you give them bicarb. Give them a bolus of bicarb and then shock them in work. If they've overdosed on tricyclics and they're seizing, you can give them Valium and Versed and Dilantin, Phenobarb. It ain't gonna work until you give them bicarb. Bicarb is what's gonna fix it for you. So if you remember nothing from what I said today except this, tricyclics need bicarb to be treated, okay? Ethylene glycol, we talked about that. Use fomepizole or alcohol to prevent the metabolization from ethylene glycol to the puric acid. Cyanide. Anybody know how to treat cyanide? Got a new monitor for that. It's called try, leave it up to fate. It doesn't make much sense to you, but when you see what it is, you understand. Try, leave it up to fate. It's called the Lilly cyanide kit. It's amyl nitrite, try. Sodium nitrite, try. Sodium thiosulfate, leave it up to fate. Try, leave it up to fate. Amyl nitrite, sodium thiosulfate. So if you're one of those people that can smell the bitter almonds, remember, try, leave it up to fate. Or just say, give me a Lilly cyanide kit. But the doctor or the PA that you're working with in PEMSHU, he's going to say, well, what's in the Lilly cyanide kit? Well, there's something about nitrite, sulfate. You'll be impressed. If you remember the real thing, that's cool too. Alcoholic ketoacidosis, it's just kind of supportive care, just like starvation ketosis. Supportive care, get some nutrition into them. Aspirin overdose. How do we treat an aspirin overdose? It always happens. It's part of split C. Salicylates. Right? Next up. Here's a reminder. Split C, salicylates. Starvation ketosis. How are we going to fix that? Oh man, that's too easy. Just give them a cheeseburger. Fix them. There's nothing to that. Well, I put that in my bottle. This is Clarissa Shields. She won gold medal at the Olympics this year in Brazil at the age of 21. She won gold medal 4 years ago in London at the age of 17. She's a young girl from Flint, Michigan. I'm the team physician for the USA boxing team. And I do a lot of fights around here. Dr. McNeil's been with me too. Do a lot of UFC. Used to bring PA students with me. Maybe Dr. McNeil can arrange it. We sew up that guy's cut or reduce her elbow. I go to fights almost every weekend. If we can somehow get Dr. McNeil to get this as a friendly companionship or a preceptor or something, I'd love to bring some students back with me.
Yes.
Even if they're just sitting there with me, because I work every weekend, I'm doing a class. All right, any questions? Yes, ma'am.
In the chart that has sodium, potassium, chloride, you put HCO, I think. We've always seen that as CO2.
Same thing.
Oh, it's the same thing.
Yeah, and it's pretty much 50-50. CO2 or HCO3. Yeah, and man, I struggled with that. When I was a student, I struggled until I finally just, I researched it, it's the same thing.
Okay.
Good pick up. Anybody else, any other questions?
There was one of the mnemonics with flumazenil.
Don't forget.
Don't forget, yeah.
Don't forget. Dextrose, oxygen, Narcan, thiamine, and flumazenil.
You said you run the risk of them going into withdrawal. Why were you given it in the first place? Wouldn't you always run that risk?
Yeah, and man, I'm so glad you said it, because it just came to me. Remember I said, Dr. McNeil, what am I forgetting? What am I forgetting? Did you know what I was forgetting?
Yeah.
Now I know what I was forgetting. Man, thank you very much, sir. Here's the problem. Benzodiazepines tend to treat seizures, right? That's what they use for seizures. If somebody sees you, you say, give them some Valium, give them some Versed, whatever. People love to take in combination benzodiazepines with tricyclics. Now, what do tricyclics do? They cause seizures. Tricyclics and overdose. You take overdose of Elavil or amitriptyline, any of those things, they cause seizures. So that's really the worry. I misspoke, and I was worried about it when I was at that lecture, at that spot, because there's something that I'm not saying here, and that's what it was. You have to make sure there's not a concomitant overdose of tricyclics. That's what we're worried about. Because if there's a concomitant overdose of tricyclics, they took a handful of Elavil and a handful of Valium. Elavil is going to cause seizures. Valium is going to treat them, so they're never going to seize. Now here you come and you give them Romazicon, what are they going to do? They're going to seize because they took this handful of Elavil over here. So that's the relative contraindication, if they've taken an overdose concomitantly of tricyclics. Man, I'm so glad you asked that question, that clears it up. There was another question in the back?
What's the next choice to do?
What?
Tell them what's the next choice when you know that they've taken both, what do you do to placate them?
If you're taking both, I'd probably start the bicarb. If they're seizing, if they're not seizing, I'm going to start the bicarb first to displace the tricyclics and then go for the Romazicon. Any other questions? You also run the risk with Narcan if somebody who's overdosed on opiates. If they're out, if they're totally out and comatose, you come on and give them Narcan, you're going to wake them up, but they may go into withdrawals. That's another mnemonic I can show you. This is another one that I like to pinpoint. Tell me the causes of pinpoint pupils. What causes pinpoint pupils? Here's the mnemonic, it's pinpoints. Take that and split it up like that. But bear with me, this is pretty good topic to know. So we got a patient with pinpoint pupils, teeny tiny little pupils. What causes that? Probably the number one thing here is pontine hemorrhage. If they've got a bleed in the pons, they're going to have teeny tiny little pupils. It's the eye, it's insecticide, organophosphates. Farmer's been out doing his fields and he's been using organophosphates. He's going to come in with pinpoint pupils. Again, narcotics. Narcotics, almost always cause pinpoint pupils. So when you're doing your physical exam on one of these guys who's overdosed and you see pinpoint pupils, hey, maybe Narcan really will work on this guy. Now there's a caveat here. Almost all narcotics cause pinpoint pupils except one. You know which one it is? No, you don't, but you will now. It's Demerol. And you know why? Because Demerol starts with a D, and that stands for dilate. Demerol tends to dilate pupils or constrict, you go either way. Why is that? It works out great for the pneumonia. Posterior synecdoche. You ever heard of that? Let me write that up here real quick. Posterior synecdoche. These are scars in the eyebrows. So you get somebody with moderate, severe, or even minor trauma to the eye. It causes a scar in the eyebrow, and what it does is it obstructs the visual fields. It's kind of a big deal because you can even get this with just a corneal abrasion as a result of a corneal abrasion. So somebody gets a finger poke in the eye, they got a corneal abrasion, they run the risk of developing a posterior synecdoche, a scar in the eyebrow of the retina, and it messes with their visual field. So the take-home point from this, and we're way off altered mental status. The take-home point here is anybody with a corneal abrasion, you need to treat them with mydriatic. You need to give them something like cyclogel or midriasil or home atropine. That does two things. Dilates the pupil, right? It prevents posterior synecdoche. So if you dilate the pupil, they're not going to get this posterior synecdoche. But it also prevents ciliary spasm. A huge component of their pain, if you get poked in the eye, you get your curling iron in your eye, a huge component of the pain is ciliary spasm. By giving them a mydriatic, home atropine, cyclogel, midriasil, it prevents that ciliary spasm. That's almost as good as Norco or Ortab for them, but it also prevents the posterior synecdoche. Don't use atropine. Atropine lasts too long. Atropine lasts 3, 4, 5 days, and they're driving down the road still seeing funny because you gave them atropine. Use the other ones, home atropine, midriasil, or cyclogel. Sorry, way off basic. Posterior synecdoche. Old age. Remember, we're back on causes of pinpoint pupils. As people get older, man, my pupils are just teeny tiny now. I'm getting so old, but look at a baby. Their pupils are huge. So it's just a natural part of aging. I love me some Blackboard. The I stands for iritis. Iritis can cause pinpoint pupils with pupillary constriction.